Good evening, everybody. Thank you so much for joining me tonight on YouTube Live. I'm Dr. Howard Elkin, the medical advocate, and tonight we're going to focus on women's health. Now, May is a very important month for two reasons. Number one, it's Blood Pressure Awareness Month, and as you know, 2 weeks ago we talked about blood pressure in great detail, and it's also Women's Health Month, so it's really a month to focus on women's health, and which is very exciting for me. So I'd like to start off with putting things in perspective with a few statistics, because I think statistics really kind of helped to ground us, you know? So if you look at heart disease, and of course, from the perspective of a cardiologist, there's about 659,000 deaths a year from heart disease. Now, that's still the number one cause of death in men and women, 1 out of 4 deaths. To put things in perspective, yeah, we've had 1 million deaths from COVID, but that's been over 2 years, like 24 months. So in 1 year, heart disease can claim 659,000 deaths. If you look at the heart attack rate, we're talking about over 800,000 heart attacks a year in this country. Now, again, it's an equal opportunity killer. Women are just as likely to have a heart attack as men, but it happens at least 10 years later. So it's a different thing in time. Now, again, so about 400,000 women die a year of heart disease. Hey, that's a lot. But in contradiction, when it comes to breast cancer, 47,000 people die. So heart disease claims the lives of women more than all the cancers combined. And it's always so much emphasis on breast cancer, but really 47,000 versus 400,000 is quite different. And here's the important thing. About 26% of women who have a heart attack die within a year, which is much higher than males. 19% of males die within a year of a heart attack, 26,000 women. I'm going to focus on that in a minute. So it's an important distinction as well. So let's talk about women's health in general. And, it's real. The dictum is really true. Men are really from Mars and women are from Venus. That book by John Gray it's really true. And by the way, if you ever get a chance to hear this guy, he's very entertaining. But nothing could be truer, more true, because whether you're talking about the anatomy or the physiology, men and women are built differently. And as a consequence, things happen differently and tests happen differently. When I was a fellow many years ago, all the things that we studied about women were based on studies from middle-aged men. Now, imagine middle-aged men could be, 45, 50 years old, and you're talking about women that are 70 and 80. I mean, that's like comparing apples to oranges, but that's all we had. And that really made things different. So not only is a difference in age when women present, there's a difference in certain things like heart, okay? Like women tend to have smaller hearts. They tend to have smaller arteries. So that's also a difference in anatomy. There's also a difference in cholesterol buildup. We all know that cholesterol plaques are one of the culprits we see in heart disease. But in men, it's the large vessels that we usually talk about that get stented or bypassed. And women, they're also large vessels. I mean, despite what you may hear, I've done plenty of angioplasties and stents in women with large vessel disease, but they also have a preponderance of what we call small vessel disease or cholesterol plaques in the microcirculation. What's the microcirculation? That's like about 70% of our circulation is micro, which we don't see it. And the women can present like they're having heart attacks, but we don't see much on the angiogram. So there's definitely a difference between men and women. Now, also the symptoms are different. Now, you hear men like that, this crushing chest pain, an elephant on their chest, and it goes down the left arm. By the way, I didn't have that at all when I had my mild heart attack several years ago. But that's the classic male presentation, right? Women usually don't have that. They may have chest pain. They may have shortness of breath or just faint-like feelings, very weakness, nausea, vomiting. One hallmark that we see often in women that's a red flag for me is they have neck pain or jaw pain. That's more commonly seen in women than in men. But here's my thing. If it's above the belly button in a woman, it's hard until proven otherwise, because it's so variable, the kind of presentations that we see. So there's also different causes of heart attacks in women. So, we know a major blockage in a major vessel, but also I've seen heart attacks in women that have spasm, meaning there's a clamping down on the blood vessel that can cause a heart attack, yet there's no real significant plaque when we do an angiogram. There's also an entity called spontaneous coronary dissection. And I've had about 3 or 4 women, usually they're middle-aged women, and it involves a small branch of a major artery, and it tears for unclear reasons. So that's another cause of a heart attack. And this other one is called Takasubo's cardiomyopathy from Dr. Takasubo. And I've had two of those. Usually it's in women, and it occurs after an emotional event, and the heart it's called the broken heart syndrome. You may have heard that before. The heart just gets ballooned and inflamed out and enlarged, and there's heart damage. Fortunately, it can come back to normal within a few weeks. And I've actually done an angiogram on a couple of these women that have had this. Fortunately, that does improve. Again, we don't see these particular entities in men. There's also different risk factors besides the cholesterol and the diabetes and the smoking, which we see in both sexes. We see things that happen during reproductive years, like preeclampsia, which is a emergency kind of situation in women that are pregnant. Gestational diabetes. Now, if you've had diabetes, gestational, that even while you're pregnant and it goes away, it still can have an impact on cardiac health later in life. And also, we're learning more about endometriosis, which is a common GYN disorder that it also seems to presage heart disease in several people, and even hypertension um, can have a long-term effect on women. So this is important. Now, besides that, there's also difference in diagnoses. We look at this thing called troponin. Troponin is an enzyme that is it's actually it's excreted from the heart, I should say, secreted into the blood during a heart attack. It means there's been some transient heart muscle damage, and we quantify that. And we can usually tell the larger the troponin release, the more significant the heart attack. In women, they seem to have oftentimes have smaller release of troponin, which means we may have to change the thresholds. We need to have sex-specific thresholds because it might be considered insignificant, may be significant in a woman. And we're just learning about that now, which is interesting. So that's the basics. Now I want to talk about heart failure too, because heart failure is the major cause of death in both genders. Major cause of hospitalization in those over the age of 75. And women tend to have, not they have more heart failure, they need to do poorly after it. And what I need to explain to you is two types of heart failure. So here you got the heart, right? And it contracts with each beat. That's called systole. Then it has to relax, and that's diastole. So it's contraction, systole, relaxation, diastole. And this is how blood is being pumped around our body. As the heart gets stiffer in women that get older, what happens is that the contraction is strong, but the relaxation is majorly delayed. Blood's not entering the way it should be. It's jamming up in the lungs, and you have heart failure. So it's not because of a poor pump, it's because of poor relaxation. And we see that more in women and than in men, and probably it's because of the basis of age. So men actually have a higher incidence of heart failure, but women usually do more poor as far as the prognosis is concerned, and they tend to be older. And what about the aging brain? Now, you might not know this, but men's brain is about 10% greater in volume than a woman's brain. But is there a risk of cognitive decline more in women than in men? And there was a recent study that I researched. It's a a study that was just released in 2021 from pooled data from 26,000 participants. And they compared women with men. And women had higher baseline global cognition and executive function and memory, but they had faster declines in global cognition and executive function. So what does that mean? It means women may have a greater cognitive reserve, okay, but they have a faster cognitive decline. So, which isn't good, right? So the reserve is better, but the decline is worse in women than men. And that's a very interesting study that was just released within the last year. What about Alzheimer's disease? We tend to think of Alzheimer's disease as a disease of aging, right? Um, so women live longer than men. So you got to know that 2/3 of adults in this country with Alzheimer's are women. 2/3. Now, in women over the age of 65, you're talking 1 in 6 versus men 1 in 11. So I know it doesn't sound fair, right? And again, it's related to age, but now we're looking at different things. We're looking at like with reproduction. When was the first menstrual period? When was the last menstrual period? What is the age of menopause? And these are things that may have an effect. We haven't figured it out yet. They're looking into now the reproductive stages of a female to come up with like, okay, is this related to Alzheimer's? So another thing that's very interesting, menopause. whether it's surgically induced or whether it's natural, under the age of 45 is not good. Not only is it a higher incidence of heart disease, but that doesn't increase the risk of Alzheimer's, which is kind of new information. So that's new information. Also, hypertensive pregnancy seems to be a correlation between Alzheimer's and cognitive decline. So these are all things that are unique to women. Now, this ApoE allele, which we've talked about before, which I know you've heard of, is it's a specific gene for cholesterol and heart disease, but also for Alzheimer's. And I think it's more common in both, but it seems that the ApoE allele in women has actually causes there's a greater risk of disease, of Alzheimer's disease. I can't tell you why, but that seems to have a greater impact in women than it does in men. We've also learned that with that allele, women have a higher loss of volume in the hippocampus. The hippocampus is a part of the brain which is responsible for memory and cognitive decline. Now, here's what everybody was told about fat gain during menopause. Why does it happen? Like, I can tell you one thing. I can tell you two things. It's not because of a lack of willpower. It's not because calories in equals calories out. I hope people have thrown that idea out, that notion out. It's really based on on changes in hormones. Okay. Now, women gain weight. The average weight gain during menopause is 15 pounds, no matter how you slice it, 15-pound weight gain for everybody. And the degree of obesity significantly increases in women as they get older, as they go through menopause. Why? Well, you have three major hormones in women that lead to this: estrogen, progesterone, and testosterone. Along with that hormonal loss, there's increased insulin resistance. What is insulin resistance? Well, what happens is that as you're gaining weight and as you get older, and because estrogen is no longer there, your body doesn't recognize insulin or doesn't use it, it doesn't utilize it correctly. So what does it do? It makes more insulin. The pancreas puts out more insulin because it's not working. Insulin's job is to take blood sugar so that from your food, from your diet, and shuttle it to the liver and also to the muscles for storage. But it's not going to happen during insulin resistance, or it happens much less efficiently. And one of the reasons is low estrogen. So there's an increased insulin resistance. Insulin resistance leads to more insulin being made. That leads to fat gain. Insulin is a fat storage hormone. So it's not willpower. It's not about calories. It's hormonal, and it's insulin resistance. And so that's the major cause is estrogen loss. There's also something else going on called cortisol because of the stress the body's going through with menopause and the stress of living in today's world. Cortisol is exploding. Cortisol is not some horrible hormone. It's an adrenal hormone, and it's their fight or flight hormone. If we didn't have it, we couldn't survive any kind of catastrophe. What happens as the estrogen goes down, insulin goes up, and cortisol goes up. So the wrong hormones are coming into play here and doing bad things. And also cortisol would also have a role with fat gain. So it's definitely hormonal. Part of it is genetic. I mean, look at your family history. Obesity tends to run in families, but we don't use that as an excuse. That's just something else. Poor eating habits. Now, women say, well, I'm eating the same. I haven't changed anything. That's the problem. You're eating the same, but you aren't really as active. You're not as active and you're not exercising. It makes it even easier for fat gain. Alcohol, taking certain drugs, antidepressants, all of those psych drugs oftentimes can make you gain weight. Thyroid function also can decrease as you get older, and that will also have a role in fat gain. So, and again, with more sedentary living. So, you have all these reasons why the fat gain happens, but really on top of the list is estrogen, lack of estrogen, and leading to insulin resistance and also cortisol production. So, how to lower cortisol? Or we can't really get rid of stress in our lives right now. But it's basically an interesting thing now in anti-aging medicine is circadian medicine, stabilization of circadian rhythm. Now, circadian rhythm is we should be active during the day and we should be sleeping at night or resting at night. But we really aren't doing that in today's world because we're working 24/7, it seems, faxes, you know, Zoom calls, and it's just an end, right? We're always working, too much screen time. And these are things that really increase your cortisol levels. So I think also if you any sleep issues at all, we should work on meditation and breath work before you go into bed. I have no problem falling asleep, but if I did, that's the first thing I do. And I think breath work is a great idea for all of us to kind of calm down. We need more Zen-like um, behavior on our part. Balancing the sugar levels. Remember, sugar levels, if they're more balanced, there's less response for cortisol, less release. Also, an anti-inflammatory diet, which is basically a healthy diet. Um, and meditation and exercise. These are the things you can do. Now, last thing, osteoporosis. And we all know that's a big thing. And again, estrogen deficiency, no matter how you slice it, it's a lack of hormones. And women have smaller, thinner bones to begin with. Okay. And they have less bone mass and they have less calcium intake than men. And they start losing bone at a much earlier age. So women greater than the age of 50 have 4 times the rate of osteoporosis and 2 times the rate of osteopenia. Osteopenia is loss of muscle, of loss of calcium, but osteoporosis is loss of bone, which is much more serious because bone is living tissue. It's not just made up of calcium. So what's the offshoot of this? Women tend to have fractures 5 to 10 years earlier than males because of this. So what do we do about all this? These are the problems that we see with menopause. Well, one thing is hormonal therapy, and I'm happy to say that I've never done any synthetic hormones I prescribed. I've always used bioidentical. So, but I think it's important to give a little brief history. So estrogen discovered by Dr. Edward Doisy in 1929 in St. Louis, and it was actually derived from a human placenta. And then by 1942, we learned that we could actually synthesize estrogen in the lab from pregnant horses, mares. And then before you know it, Premarin was born in 1942, and it was indicated for women with hot flashes due to menopause. But then in 1966, what really populated estrogen was this book called Feminine Forever. Can you be feminine without estrogen? And oddly enough, it was written by a male. That's right, Dr. Robert Wilson. He said you could stop a woman's living decay with estrogen. Like living decay. Isn't that terrible? Anyway, then in the 70s, we learned more about the risk of estrogen with uterine, the uterine lining, and eventually causing cancer. So then we added a synthetic progesterone called progestin to it. And then by 1977, this Dr. Barbara Seaman, a woman, she came out with a book called Women in the Crisis of Sex Hormones. Warning, these are based on small studies, but we learned that hormonal therapy can lead to increased blood clots and strokes. So there's a question of safety. But then in the next few years, that all went by the wayside because studies came out in the 80s and 90s touting the positive effect on hormonal therapy on the heart. And that was kind of a big thing. So I'm going to jump a few studies and just go to the big one, which is the Women's Health Initiative, which was in 2002, 160,000 women. This study was halted before it could be completed because we learned there was an increase in heart attacks, strokes, blood clots, breast cancer, ovarian cancer with the use of these hormones. And then all of a sudden, half of the women in this country were taking off their hormones. Half. And that's how I kind of got into the game. Now, what you need to, and this is what happened is that nurses and teachers in my area came to me and said, you got to help us, doc, because the gynecologists in this area don't know from Shiola. They really don't. And, we need you. I was kind of holistic minded. I said, okay, I'm up for the challenge. And I learned quickly, and I took a fellowship in anti-aging medicine. And I started working with women and I saw results. And then Suzanne Summers' book came out a year later called The Sexy Years. Then I didn't have to look for, I said, just read Suzanne Summers' book and you'll get a good idea. And that really paved the way, not just in my practice, but really over the entire nation. It really brought people attention to the goals of what the benefits of hormonal therapy, but it was bioidentical therapy. Okay, and that's what you need to know. So the therapy that we've used traditionally in the past has been synthetic. So it's derived from the urine of pregnant horses. That's Premarin, been around since 1942. And the other one is Provera now with synthetic progesterone, which is 5-hydroxy progesterone acetate. Does that sound anything like natural to you? I don't think so. And it's not natural. That's what they used. And the Women's Health Initiative, which had really negative results, was based just using those hormones. So we really didn't have anything to go on. First of all, if you look at the pitfalls of that study, the wrong age. The average age, first of all, the age span was very high, but I think the average age was 61 or 62. And that's way past menopause already in most women. So the wrong age, the wrong estrogen. Okay, so they used anything but natural. They didn't use natural estrogen. They used derived from urine of pregnant horses, and the wrong formulation. They used an oral form of estrogen, which can go with, if you know anything about the first pass, things go from the gut to the liver, where it's metabolized, and oftentimes get metabolized something that's more inflammatory. That's the last thing we want is more inflammation. If you've seen any of my other previous podcasts, my talks. So enter the world of bioidentical hormones. So there's three major hormones, three estrogens you have to know about. Estriol, which is a major hormone during pregnancy, which is the mildest. Estradiol, which is the estrogen that women have during their childbearing years. And estrone, which is anything left over past menopause. So with bioidentical hormones, we do a formulation based on these, and they're bioidentical because they're about as identical as you can get. They're derived from wild yams and also soy, but not it's natural soy is what I should say. And instead of Provera, we use natural progesterone. And it's really important. What I look for is in balance. So estrogen gives women a sense of femininity, energy. It's good for the bones, for the heart, and for the brain. Progesterone is the calming hormone, the Zen-like hormone. You really need balance. And that's what I look for in my women. I look for the balance of the estrogen and the progesterone. So a couple of the things, that's my verse. So my personal view is that no person should have to go through painful menopause in this day and age. Now, and I am biased because I'm anti-aging. So I actually think that women and men look better, feel better, and think more clearly on hormone replacement therapy. Does that mean I recommend it to everybody? Absolutely not. It's an individual decision that has been made by and each woman has to make their own decisions. And by weighing the pros and cons, I think the pros outweigh the cons. But again, it really depends on the desires of the woman. What do they want to achieve? And so that's how I do it. There are some natural remedies as well. And like, for example, phytoestrogens, which are plant-derived estrogens, can help with boosting your estrogen level. They mimic the effects of estrogen, but they can also disrupt it as well, endocrine disruptors. So you have to be careful with it. It's a little controversial. So lignans, flaxseed is very good. Isoflavonoids, resveratrol. Also things like nuts and garlic can also help. So there are foods that can help with estrogen. And also certain vitamins, B vitamins, vitamin D, boron, and DHEA, which is another part of my arsenal when it comes to anti-aging, which can also can also help with estrogen. And there's also herbal supplements, but they mostly deal with the symptoms of menopause versus actually increase estrogen levels. So again, when it comes to weight gain, it is hormonal and insulin resistance. We talked about what certain diets can do, but certainly hormonal therapy can be a major boost, and it can increase the metabolic rate. But I also use progesterone and DHEA. They can also help with weight gain. Pregnenolone also inhibits the production of cortisol. So, that's it in a nutshell, which is a lot of information. So the hormones can help with the heart health, with the bone health, the brain health, the fat gain, and also skin, which we didn't really get into. So I know I went over, guys. So please, I got a lot of questions here. So let me look at my glasses on. Okay. Give me 1 second to go to the top here. Thank you. Okay. Thank you for the thanks. Let me see if I go down here. Okay. If my wife and I are in our 50s, is it too late to do a calcium score test? No, it's never too late to do a calcium score test. Calcium score test we'll talk about in the future, but no, it's never too late. Okay. What supplement would you recommend to women to keep the heart healthy? Well, that really doesn't, whether it's male or female, keeping your heart healthy, it's going to be diet, lifestyle first. Diet and exercise is always going to be number one in my book, diet and exercise. Supplements that really help with heart health, of course, I'm very basic. I'm a big fan of coenzyme Q10 and fish oil. Those are the two that I use. I'm very simple. I don't get into exotic symptoms, exotic supplements, unless I think it's really necessary for just to maintain a healthy heart. Coenzyme Q10 and fish oil. Okay. Is there different types of cardiomyopathy? Yes. I talked about Takasubo cardiomyopathy, which is specific heart damage due to an emotional event that we see in women. It's poorly explained. We also have a dilated cardiomyopathy, which is what happens when people, that could be due to a virus. It could be due to, oftentimes it's called idiopathic, which means we don't really know why it's there. Then there's ischemic cardiomyopathy, which happens with people that have had repeated heart attacks and damage to their heart muscle. Then there's another one called hypertrophic cardiomyopathy, which is due to a very thick heart that doesn't relax well. It's an extreme situation. So yes, there are different cardiomyopathies. Okay, can a crease in our earlobe mean heart problems? That's an old wives' tale, and I've heard about it since I was a student. I don't really know if I've never seen any science behind it, but it's I've never, I don't know, I can't even explain it. Okay, how can the FDA allow pharmaceuticals online? Yeah, I've heard about this. As far as FDA allowing pharmacists and online sellers to prescribe birth control, are there risks? Absolutely. First of all, only a doctor should be prescribing birth control. I don't really prescribe birth control. I think yeah, it's great for birth control, but it's lousy for the heart. It's lousy for libido. It disrupts your hormones. The list of potential problems with use of birth control agents is a multitude. And I've had two patients in my career, one that had a major stroke, one that had a major heart attack in her 40s. A lot of doctors will prescribe birth control pills to women in their 40s to regulate their periods. Well, why do you have to regulate your period in your 40s? You're not going to have kids anymore, usually, number one. And number two, that's what normally happens. When you go through perimenopause, your periods become less regular. And then you can have two periods 1 month, or you can go 2 months without a period. Why are we trying to regulate that with birth control pills? I never could understand that at all. So I don't use birth control pills um, myself, and I never have. Okay. Does hormonal therapy work? Absolutely. It works in both men and women. Again, I said before, it is an individual decision, and I suggest that you read a lot. I think Suzanne's book, the first book, is still great, The Sexy Years. But again, we talked about um, all the problems that befall menopause, and most of them can be improved with the use of bioidentical hormones. But make no mistake about it, it's not about that and not lifestyle. If your diet sucks and if you aren't exercising, I don't care. Hormones are not going to be the key to your problem. So I'm always, always, always lifestyle first. Medicines and hormones are medicines, or come second. Latest in my book. Good, great question. Okay. I'm almost ready for the launch, you guys. It's a lot more work than I thought. I mean, all I did was write the book and edit the book. I didn't know about all these other details about launching and pre-launching, all that stuff like that. So you'll be the first to know. I'm hoping in the next month. There's a few things we've almost completed the website. So it's going to be great. I'm really looking forward to that. We'll talk about it. Okay, I think that is it. Thank you guys for your attention. Now, next month is June. And fellas, June is Men's Health Month. So you are not being left out. So please join me next month. It'll be 2 weeks. And as we go further into June, I'll be talking more about my book and what you can expect. But I think it's going to be a really good thing. I'm looking forward to it. As usual, I'm very grateful for you joining me on YouTube Live tonight. Please share this with your friends. Please subscribe. And also, if you see any of my videos, I appreciate if you click the like button. It really does help. And oh, wait a minute, I got another question here. Okay. Okay. This is another wives' tale. If I take hormones, should I stop after a certain age or stop after 5 years? That was based on the hormones that we don't use anymore, Premarin and Prempro and Provera. With bioidenticals, when should you stop them? Forever. You could take them forever, as far as I'm concerned. Why would you want to stop something that's helping your cognitive function, or your heart function, or your cholesterol levels, or your bones? If you're getting benefits, there's no need to stop. But that what you're hearing is from based on synthetic hormones. So forget what you learned. There's no need to stop hormones once you're on it. And you may say to yourself, okay, well, are there any downsides? Most of us in the field, in functional medicine and longevity medicine, do not feel that there are any major drawbacks. Will we ever know for sure? No, we won't know for sure because there's no big study out there that's going to look at all these compounded medications that we use there's no money in it. There's no money in bioidentical hormones. So we're not going to get, randomized, double-blinded, placebo-controlled study. It just ain't going to happen. So we have to base it on what we're seeing. But I've been doing this now, cardiology for 35 years and longevity medicine for 20, and I've never had a problem. But I follow my patients carefully, and we look at how they metabolize their estrogens, which is very important. So, and that's why if they don't get tested, we stop the hormones. I will not carry on with hormone replacement therapy if a woman doesn't comply with follow-up, and the follow-up includes urine testing at least once a year. And I'm sorry to say that insurance is phasing that out, so it's going to be a cash thing from now on. That's what it seems to be. But it's very important to know that if you're metabolizing it in a safe way, even though bioidentical hormones are extremely safe, I want to make it super safe by making sure you metabolize it in a healthy way. So it's really important. Okay, let's see. I think that's about it, guys. I kept you long enough. Again, thank you. I'm very grateful. Check the click button. And please share with your friends, and I'll see you guys in 2 weeks. Thank you and good night.